well known to all of us, and she is going to talk to us on nutritional deficiency in IBD. And after this, co-sharing the entire moderator role with me is Rupa, who is the director of our IBD clinic, and under her leadership, we have got Partha here who works together. We have made great progress in this field. So I'd request Usha to take the stage and talk to us on nutritional deficiencies in IBD.
Thank you, Professor Tandon, and thank you, Rupa, for inviting me for this meeting. As we all know, diet is a very important cornerstone in the management of IBD. That's because the patients keep coming and telling us that 40% of them believe that diets trigger the flare, and 80% believe that diet has a key role. Quite often the spouse is the one who tells us he ate this and after that there was a trigger, and he eats a lot of these things and he keeps having a GI issue. So quite often we hear this from the patient, but however we do not have good evidence to know how to use this very important trigger in the management of IBD patients. So patients quite often ask us, what can I eat, what should I not eat? But we are usually not sufficiently informed about the evidence related to diet, and hence we remain silent or give some non-specific advice. And this results in our patients going to internet, WhatsApp, families and friends, alternative medicines who step in to give advice. And this is where we lose our patients, trust in us, because in Indian form of medicine or Ayurvedic form of medicine, homeopathic form of medicine, there is always a lot of importance given to diet. But unfortunately, modern medicine doesn't look at it from that perspective. So there comes a divide in our understanding our patients' problems and psyche. So diet is actually a risk factor for IBD, as well as it results in a flare of IBD and has a role in IBD complications. And diet also has a role in prevention of IBD, reducing disease activity, has a role in correcting malnutrition and reduces the risk for malignancy. So diet has a preventive role, treatment role, and has a role in reducing the disease activity, changing the course of the disease. So diet in the pathogenesis of IBD, in IBD we know genetics, environment and microbiota, all the three together play a role in causation of IBD, of which among the environmental issues it is diet which has a predominant role on modifying the microbiota, and that may result in increase in IBD. So changing diet has pattern over the decades has resulted in increase in IBD. First of all, there was the Paleolithic diet, and then came the agricultural revolution, and now we have frozen foods and fast foods. With this, there is reduction in diversity of the food that we eat, and the diet has become more pro-inflammatory. Western diet, the traditional Western diet, which has red meat, has a lot of fried food, and has a lot of processed food and a lot of sweets, and high in N6 PUFA, refined sugars. These are triggers for IBD, whereas the traditional healthy diet, which is based on fish and has a lot of vegetables and high in N3 PUFA, has an inhibitory role in IBD. So there is epidemiological evidence for all this. I cannot go into each of the details, but I can let you know that the Western pattern of diet high in sugar, high in red meat, high in fat, high in protein, high in iron and sulfur containing amino acids, and a child who has not been breastfed, alcohol in the form of whiskey, which is associated with increased risk, minerals such as iron, aluminium and titanium, and processed food and meat. All these in red are associated with increased risk. Whereas the protective diet are the traditional diets, which are rich in omega-3 fatty acids, fish, complex carbohydrates, red wine intake, vaginal delivery, because this decides the flora in the gut of the neonate, zinc and vitamin D supplementation, natural food, as well as fruits and vegetables are associated with protective factors. How does diet trigger IBD? Diet has various effects on the gut. One is it dictates the flora. Second is certain kinds of diet have an effect on the mucus. It is associated with impairment of barrier function, especially spicy food and food which is rich in fat. Immune regulation is also dictated by the diet, and the antigen load, especially with milk protein as well as gluten, All of these can trigger inflammation. So the effect of food on diet, if you see here, there is wheat, which adds to gliadin, which increases the paracellular permeability and thus allows the bacteria and the pathogens to also enter and stimulate the immune system. Apart from that, saturated fat and high fat diet also results in increase in the gut barrier and changes the flora and results in stasis. Also, all these polysorbates and various things can also cause epithelial injury and acts on the glycocalyx as well as the mucous cell membrane. Diet can also affect motility, where high fat diet, low potassium diet, low calcium, low magnesium, all of them can make the gut go slow. If the gut goes slow, there will be bacterial overgrowth, which will result in dysbiosis. If the gut goes fast and there is no sufficient time for digestion, then it will lead to undigested food getting to the lower gut and hence will promote dysbiosis. So appropriate motility is necessary for appropriate digestion and having a control on the gut flora. So the evidence in this area is very weak. So you will never get odds ratios of more than 2 or 3. Maximum it will be 1.5, 1.7. So that is why the evidence for diet, role of diet in IBD control is weak. But however, it is a very cheap intervention. It is an effective intervention and it can be used on a daily basis. So chronically diet would affect the ultimate activity of the disease. So it will obviously not be as effective as a biological, but because diet is a daily thing, handling diet is very useful in controlling disease activity. So what are the key ingredients of diets which we can modify? One is fiber, second is the amount of vegetable and fruit intake, amount of red meat intake, sugar, milk and gluten. So these are the common triggers we have to modulate. Fiber, it is very clear. High fiber diet is associated with reduced risk of CD as well as UC, and recommended amount of fiber is 24 grams a day, which in our patients in India, if you just tell them to take whole wheat and whole grains, they would get their fiber along with fruits and vegetables. Fruits and vegetables per se reduce risk for UC as well as Crohn's disease. So this is something which we should actively recommend our patients to take, high fiber diet through vegetables as well as fruits, because it has also antioxidants. This is a big no-no, that is red meat. Red meat, especially if it is darker and more processed, is that increases the risk for UC as well as Crohn's disease. So I tell my patients that they can preferably take fish, or else they can take chicken, but not very frequently, not more than once a week. Long-term high-fat diet is associated with increased risk for IBD. N6-PUFA is a pro-inflammatory agent, and N3-PUFA, that is polyunsaturated fatty acid, is an anti-inflammatory agent. So if we have more of anti-inflammatory oils and less of the pro-inflammatory oils, if that ratio is appropriate, it will be ultimately beneficial. So N3-PUFA is associated with decreased risk for UC, and trans fats in stored food is associated with increased risk for UC. Trans fats is a very important thing in India, especially when people eat outside food where oil is used repeatedly for making food. So trans fat should be totally avoided. So long-term fat intake, we have to see that anti-inflammatory oils are MCT, that is medium chain triglyceride. Coconut oil is a classical medium chain triglyceride which is incorporated in natural diets of people in Kerala and other parts of India. However, fish oil is another thing which people can take as supplements or take fish itself as an anti-inflammatory agent. The pro-inflammatory oils tend to be the mustard oil, the soybean oil, the saturated fats and the milk fats. So it is good idea to restrict the use of this and increase the use of this. There is a lot of controversy regarding gluten-free diet. There was a study done in US in a large number of subjects, over 1,600 patients, where 8% patients voluntarily were on gluten-free diet. 33% had tried gluten-free diet sometime or the other, even though these patients were not diagnosed celiac patients. So they found that when they tried gluten-free diet, 63% improved their activity, and 38% there was reduction in frequency and flare of the disease. However, we cannot recommend gluten-free diet in patients because we do not have sufficient evidence that recommending gluten-free diet will result in improvement. The other thing is that this gluten may be restricted during flares when there is increase in disease activity, because gluten is an immunogenic protein. Milk is another thing which many people tend to self-restrict. 65% of our patients with IBD tend to self-restrict milk. So I tell them that it is better to take a lot of curd if they are finding problems with milk intake. They often find that with milk intake, there is increase in the stool frequency, and 70% of them are lactose intolerant. So I ask them to take cold milk in small quantities and take milk along with their food to reduce the gastric emptying resulting because of hot milk, as well as they can take dahi or curd, which is the standard buttermilk or dahi. So these kind of things they can take in order to provide them their calcium source as well as their protein source. The interesting thing is that saturated fat in milk increases a particular bacteria called D. piger. This is a sulfate reducing bacteria which has been shown to increase in patients with IBD flares. Also, the permeability increases of the gut with milk intake, and milk intake has a pro-inflammatory effect on the gut. Milk protein can also trigger IgG4. It increases motility, but no milk, especially in a country like India and in Asia, it will result in nutritional deficiencies amongst the vegetarian population, and milk is an important source of calcium and protein. So excluding milk is not recommended. There is grade A evidence, level 1 evidence for that. So I ask my patients to take either in the form of curd, or they can take small quantities of cold milk along with their food. So homemade curd is a good option because it has probiotics, it has high mucin as well as increased lysozyme and increased calcium absorption. So when we assess nutrition in patients with IBD, there are two large studies, one by Dr. Ghoshal et al., who's already on the panel here, where they have shown that IBD patients are malnourished. So they have decreased calcium intake, they have decreased iron intake, their BMIs are low, their bicep skin fold, tricep skin fold, all of them are lower. Another study from Govind Makharia has shown that prevalence of malnutrition in CD is higher. So overall prevalence of malnutrition is high in these patients. So macronutrients are deficient. When we look at the composition of body analysis, there's a lower lean mass, lower BMI, and patients with longer disease duration have significantly lower nutritional status. So diet has to become an important part in the treatment of IBD because diet has a role in the pathogenesis, diet has a role in the trigger of the IBD, as well as IBD patients are prone to malnutrition. So first thing which people tried was, can fasting improve IBD? But there fasting is not advocated because fasting patients are not able to tolerate and there is no reduction in disease activity. So fasting is not the option. Next comes, can we use exclusive enteral nutrition or partial enteral nutrition or elimination diets? So these are the three types of diets which have been tried in patients with IBD. Exclusive enteral nutrition especially is useful in patients with Crohn's disease because of ileal involvement. Here you do not give them any solid food, you give them only tube feeding with special formula feeds for 6 to 8 weeks, and then you shift them to partial enteral nutrition, and this has been shown to restore the gut mucosal integrity. And what types of exclusive enteral nutrition we have? We have three types: elemental diet, semi-elemental diet, and polymeric diet. Elemental diet predominantly has amino acids, glucose, and MCT. This has to be given usually through a tube because it is not palatable. The semi-elemental diets are usually also given through tubes. These are oligopeptides as well as MCT-based diet. The polymeric diet are complex carbohydrate, whole protein, and these can be taken orally by the patient. So there are various types of exclusive enteral nutrition. And the Asian guidelines say that there is no difference between elemental and polymeric formulas. So we should preferably use polymeric formulas because they are cheaper, they can be made in the house, it doesn't increase cost of therapy compared to elemental diet. Second is exclusive enteral nutrition is as effective as corticosteroids in pediatric Crohn's disease, but in adult Crohn's disease, it is inferior to corticosteroids. But you can use exclusive enteral nutrition as an add-on therapy in patients who are steroid dependent, refractory or intolerant. So basically exclusive enteral nutrition is very useful in pediatric Crohn's. In adult, it's an adjunct component, and we can use polymeric formulas in India. Elimination diets, various types have been tried, but they are of limited efficacy, so we do not usually advocate elimination diet. The Asian guidelines also does not recommend elimination diet in IBD. So how do we approach a patient who comes to you with IBD? We assess their nutrition, we assess their BMI, we assess their do a DEXA scan to assess their osteopenia. Then we do a must analysis for their nutritional status and a subcutaneous fat analysis. They are likely to have macronutrient and micronutrient deficiency. For our job is to assess them and correct them, and also look for unnecessary dietary restrictions the patient has self-imposed on himself. So we assess if the patient has active disease, we restrict the triggers like masalas. They can avoid the chilies during that time. They can avoid any gluten during that time. They can avoid the self-reported triggers at that time. And at that time, we can give exclusive enteral nutrition. When the patient goes into remission, they have a component of functional bowel disease. There we can keep them on FODMAP or gluten-free diet or milk-free, depending on what is the nature of their functional bowel disease and depend on the patient's individualized therapy. If they have a stricture, we should put them on a low residue diet. If they have fat malabsorption, we can add some pancreatic enzyme supplementation. If they have kidney stones, we have to increase the fluids in their diet and restrict their oxalate intake. So what would you prescribe a patient? You ask them to take minimum 1 to 1.5 grams of protein if they are having active disease, otherwise 1 gram if they are in remission. Legumes, vegetable proteins and fish are good sources of protein in them. Egg is also another option if egg does not flare up the disease. Fat, we usually advocate low fat diet, MCT based diet, olive oil. These would be the ideal oils which they can tolerate. Carbohydrates, we ask them to take easily digestible cooked carbohydrates and primarily rice based as well as fermented grains with a lot of fruits and vegetables. Micronutrients, they are usually deficient in A, D, E and K, zinc, folic acid, iron, calcium, magnesium, potassium, B1, B6, B12 and selenium. So we can usually only check for iron, calcium and vitamin D and B12 in our routine laboratory practice, and we can check for that and supplement them. So it is a good practice to add a multivitamin daily and add a tablet of zinc into about 10 to 20 grams a day, because zinc has a role on gut immunity as well as gut barrier. There was a study which has shown that nutritional deficiency is very common in patients with IBD, and even if they are in remission, they are more likely to be nutritionally deficient. And the common ones are vitamin D, zinc, multivitamin B6, as well as vitamin C and B12, and many of them may be iron deficient, and they may have high ferritin levels, though the ferritin levels are related to their disease activity. So ferritin is a poor guide in these patients. We did a study on vitamin D, and we found that patients who had IBD had significantly lower vitamin D levels compared to their controls, to a tune of 18 nanograms per ml. And a meta-analysis on vitamin D deficiency shows that patients with IBD tend to be vitamin D deficient. So the risk of vitamin D deficiency is nearly 2 times in adults. In another study which we did, we gave active vitamin D, we gave nanovitamin D, and we found that with improvement in the vitamin D levels, the disease activity reduced, and the histological scores also reduced. We also found that with improvement in vitamin D levels, the CRP levels went down, and with the calprotectin levels went down, and all of these were highly statistically significant. Another interesting thing in this study, we found that the improvement in UCDAI happened in those who had reached a target vitamin D level of 40. And here you can see on the x-axis, you have vitamin D levels of 1 to 20, 21 to 40. This is post-treatment vitamin D levels. So those who reached a level of 40 had a better response in UCDAI. And that is why we have in our lab, in our IBD clinic, ensured that we target vitamin D to a level of 40. There are other phytochemicals which are of use: curcumin, ginger, cinnamon, grapes, green tea, apple, honey, and bael. All these have again very small odds ratio, but may be effective in a couple of patients. So curcumin has been used for induction of remission in patients with UC. So there has been significant response by about 4 weeks in the curcumin group compared to the placebo group, as well as endoscopic response and healing has been higher in the curcumin group. In another RCT in 45 patients from the AIMS group, they had shown that curcumin enema is effective compared to a placebo enema when they were assessed at 8 weeks. In another multicentric study, giving curcumin resulted in reduction in the relapse rates of patients. We did a study on turmeric, and we gave 5 grams twice a day of organic turmeric, and we found that it reduces calprotectin, reduces inflammation, and had high patient acceptability because it was of low cost. Probiotics have been tried for inducing remission in UC, and they have found that BSL-3 has a benefit in induction of remission in patients with UC, and the number needed to treat is 5. But however, the evidence of probiotics is very limited. Given the cost of therapy, it may not be an option unless we do not have any other options working in that patient. Probiotics in preventing relapse of UC, it has been found that it is as effective as 5-ASA in preventing relapse in UC, but no benefit in CD. So until we have more evidence coming up, I think the best thing which we have is our grandma's recipe of using khichdi, which has combination of curcumin. It has combination of fiber. It's soft in consistency, easily digestible, easy to prepare, and acceptable in our community. So I'm sure in the Asian communities there will be something equivalent, which is rice, vegetable, and legume based food, which they can try. And we have, along with that, if you have dahi, which is curd, which has probiotic property, calcium, protein, low lactose, and homemade. So this is a homemade grandma's recipe, which may still be beneficial in patients with IBD. So the food which they can take a lot are fish, fruits, vegetables, and dahi. And the foods which are a big no-no are fast food, red meat, and all the masalas which are used in routine cooking, as well as processed foods. And another thing I tell my patients is to use home food rather than outside food, because outside food may not be so hygienic, will have high fat content, and will have a different kind of antigen profile which may trigger their GI system. So the do's and don'ts: assess their diet, assess their nutritional status, counsel them about IBD safe food, correct their micronutrient deficiency, find the triggers, advocate healthy, hygienic, balanced meal, and trust the patient's gut instinct, because patient can tell you that this thing doesn't work for me. So there is no need to put your textbook before the patient's gut. We just let the patient choose his diet. And the important don'ts are: don't eat outside food. If you have to go for a marriage party, eat at home before you go out, and choose only your food very carefully when you're outside the house. Avoid trigger foods. You can take a small quantity of them in remission. Avoid overeating, eat small and on time, and avoid spicy foods. So instead of mirchi, you can take pepper, which has more GI friendly. Avoid sugars, take jaggery. Avoid red meat, you can take fish and poultry, and avoid NSAIDs. This is a very common trigger I find in patients, that whenever they have pain, they take NSAIDs. So I tell them to take paracetamol instead, which is less likely to cause a GI disturbance. So eat for your gut rather and satisfy your tongue. So small amount for the tongue, and the rest of the food is for the gut. Thank you.
Thank you, Usha, for a wonderful talk as usual. We will take all the questions at the end of the session.
Okay.
And I think we will go on to our next talk and elaborate more on IBD and diet. Our next talk is by Nilanjana Singh, and her talk is going to be on dietary do's and don'ts. To briefly introduce Nilanjana is a well-known person in the dietetic circle with more than 30 years of experience. She is a registered dietitian, an educator, author, columnist, and wellness consultant. She has extensive clinical experience at AIMS, PSRI, Sitaram Bhartiya, as well as the Diabetes Foundation in Delhi. She's been the president of the Indian Dietetic Association Delhi chapter and is currently the national executive of the Indian Dietetic Association. She's a weekly health columnist for the Morning Standard and the Indian Express for many, many years. Her best-selling book is Our Kids Eat Everything. Why Should I Eat Healthy? Fight Cancer with Flavor. And they've all been well read over the last few years. It's indeed my pleasure that Nilanjana has been able to join us today, and we'll be talking on IBD diet, do's and don'ts from the dietitian.
Thank you. Thank you so much, Rupa, for the kind introduction on giving me this opportunity to be here in this August gathering. And before I start, I want to remind you of the PSRI days when I was writing this chapter on nutrition and IBD, and you gave me very valuable inputs, and I loved those discussions. I still remember them. I hope you remember them too.
I do, Nilanjana.
Yeah, so let me get on. So, Rupa, you can stop me if I'm exceeding my time. You can let me know. I know you've told me to talk for 15 minutes, and Dr. Usha has made my job much easier because she's given an excellent background to my talk. So maybe there's a lot of overlap between what I am going to say. So I might skip some portions, but please feel free to stop me if you have to. Okay, so the role of diet is changing. At one time, it was looked upon as just an adjunct or a side treatment, not taking the limelight. But what we know today, as Dr. Usha said, that right from the etiology to how it modulates the disease and the risk of complications, in all of that, diet has a role. And what is very attractive about diets is that it can be done on an everyday basis. It's low cost, easy to modify, and few side effects. So that is why the focus on diet, and I'm so happy that this program is there and given the importance to diet. How does diet work? Maybe I will not talk so much about it because Dr. Usha has already mentioned that the dietary components act in many different ways. But I think the most important way, or what is occupying the limelight, is the way it alters the microbiota or the microbial structure and function. And through that, the immune activity. Also, the mucosal permeability is affected by diet and the immune response through the dietary components. So in many ways, the diet works to either increase the risk or decrease it. So we'll just look at that. This is a study which I like to show. It's not very recent, about 10 years old. But here the impact of diet in shaping the gut microbiota was revealed very clearly in these different children from different parts of the world, in Europe and rural Africa. And what was really, this was one of the studies that started showing that how diet has an impact on gut microbiota. And the lesson that was learned here, and many studies then replicated it, that diet had a dominant role over all the other variables that were studied, and this altered the gut microbiota the most. Which is why there is this huge body of research going on in the last 10 years where the gut microbiota is being studied, and its links to immunity is definite, and also mental health now. I think that is the focus. But right now we're talking about the gut and how it affects the risk of IBD and how it affects the treatment. Currently, there are about 25 diseases that have been linked to the gut microbiota imbalance, and IBD is one of them. And what we know that there is definite dysbiosis seen in IBD, and what we know that in IBD, actinobacteria and proteobacteria, the ones that are associated with the bad kind of disease, is definitely increased in numbers, and the good ones, the Firmicutes and the Bacteroidetes, are reduced. So we know that diet and microbiota are connected. So here we start focusing on what to do in the diet. Like Dr. Usha mentioned, the various diets. So when you look at these diets, you are obviously confused. Which diet do I choose? Do I choose the Mediterranean diet, low FODMAP? And it can be a little overwhelming as to which one would be the right one for my patient. So personalized nutrition, personalized medicine, all of that is making a definite impact. And we know that one size does not fit all, and particularly so in the case of IBD. So we cannot say that this one particular diet scores over the others, and this will work better for all patients. So each one of us working in this field have to work on an individualized plan for each of the patients. So my first do is customize your diet. And this you can only customize after you understand the disease severity, the extent and the duration of the disease. You see whether the patient is a child or adult, whether it's which form of IBD, and whether it's in the active stage or is it in remission, whether there's a stricture or no stricture. And if the patient is well nourished, because you do a nutritional assessment. The second do, very important, you need to track and record what's happening to your patient's diet. And the AIMS team has come out with an app which is getting very popular, the IBD NutriCare app, and every day I know that they are working to improve it, and it's getting easier to use. So that's very helpful. But those who are not into using apps, they can just journal, and journaling is important because it helps to identify the troublemakers in the diet, and you exclude only the troublemakers. You don't want to exclude more than that. So you pay attention and you see how your body responds, and the common troublesome foods have already been discussed by Dr. Usha. So we all know the common ones, but everybody is different. You need to identify what it is for you. Another do for IBD diets is learning the art and the science of substitution. And although we know that we don't have to restrict milk unless the patient is intolerant to it, but very often we find that patients complain of lactose intolerance. In that case, we tell them to have low lactose products like paneer and dahi, but just in case they do not tolerate that as well, you have other options. And with plant-based diet becoming popular, you have more and more of these options coming in. Similarly, if you have to substitute wheat because of gluten intolerance, you have very many millets. I know ragi in the south is very popular. It's very rich in calcium and iron, so it's one of the popular things that can be used as a substitute. Substituting alcohol, I know this is a difficult one when you have to substitute alcohol, but fermented drinks are good. You have the kanji, buttermilk, and red wine also in some amounts are allowed. We are a carb-loving country and we love our carbs, but sarcopenia is common, so we have to think about protein in every meal. You cannot let any meal be without a good dose of protein, and you can choose from any of these products, although the patients might be a little skeptical about using seeds or using nuts, but you can make them into nut butter, you can soak them, you can powder them, you can use sesame seeds, which are calcium rich, you can use them as a powder in almost all foods and they go well with that. Lentils, if they are soaked overnight, cooked well, do not pose a problem. And egg and fish, of course, are good protein sources. So you cannot stop thinking about protein at any meal. So whether it's a snack or whether it is something that goes in between meals, think protein. Different kinds of fats are there, and the one that you need to focus on is N3 fatty acids, because our diets tend to be skewed in favor of N6 fatty acids. So you need to think about those sources which have N3 fatty acids, and I have listed some of them. The fatty fish that we have in many of the coastal regions that we can get, they're easily available. These fatty fish are good sources. And of course, in the oils, Dr. Usha mentioned that mustard oil was pro-inflammatory, but it has N3 fatty acids, which is anti-inflammatory. So it sort of evens out, and we need good sources of fatty acids. So we recommend mustard, soya, canola, which have N3 fatty acids. And if they don't want to use any of these oils, we tell them to use an oil which has a good balance. Which does not have too much of N6. So that is the strategy that one can use to make sure that you get enough N3. Once you detect and you find that there is nutrient deficiency, you need to give a supplement. It could be an oral nutrition supplement, and the good part is the polymeric formulas are just as good as the elemental one in efficiency, so you don't have to give those bad tasting ones, and patients are more compliant in taking that. Of all the nutrient deficiencies, vitamin D and zinc are the ones that one should focus on because they alter the disease course. So you cannot let these deficiencies linger, and you need to make sure that they are covered. About probiotics, there is a little bit of conflict or not very too much clarity about probiotics because the different guidelines recommend different things. So what we generally try and do is, of course, we don't give probiotics in Crohn's disease because there's no evidence for that. But in ulcerative colitis, we can add probiotic foods. I'm not talking about supplement. There are foods which have probiotics added to them, which can be part of the healthy diet, which every healthy person as well as somebody who has ulcerative colitis can add to the diet. And fermented foods are very good. They don't have the evidence as probiotic foods have because they have that body of research backing it. Fermented foods have been around for a long time. We know that they are good for health and they should be included because they may not have the dose of the bacteria in it, the specified dose, but it's definitely something that keeps the gut healthy. The other, before I start with the don'ts, I think the first important don't, which is a big problem in IBD, is that patients tend to be overly restrictive and they try and cut down. They're so scared of eating things that they try and cut down one thing after another, thinking that that will give them relief. But your job as a dietitian would be to find out the trigger and just restrict that, because we don't want the gut microbiota to disappear, which is happening with processed foods. So as a dietitian, I think we have been thinking about our roles, and our earlier role was to cut back and tell people what not to eat. But I think our role should be changing, and we should be telling people what you can add to the diet, which is healthy. And believe me, it's a much easier thing to do, telling people what you can add, because telling people not to have something can be a problem. And this was a study which was interesting, that when you added 30 different types of plant-based foods and compared them to a group which ate only 10 different types, the one which had the 30 different types had better gut health, and this better gut health means better gut bacteria, and this is a good marker for health. So the diversity on the plate shows up in the gut and in terms of the gut microbiota. So more diverse the diet and more of plant food, the diversity improves on the plate and in the gut. Not to do, one of the things is not too much of saturated fat. And again, this was mentioned in the earlier presentation, that we don't want to increase the population of the microorganisms that increase inflammation. So in that case, we have to keep the saturated fat low and keep the N6 PUFA low. So not too much of corn, curry oils, which have too much of N6 PUFA. And this is backed by evidence. In ulcerative colitis, high saturated fat was associated with the risk of more of problems. And in Crohn's disease as well, it improves when you have a high ratio of N3 as opposed to N6, then it improves the remission rates. FODMAP diets have been known to reduce the symptoms, but it does not mean that you have to be on a FODMAP diet, low FODMAP diet forever. As the tolerance increases, you can add FODMAPs back into the diet, because these are all sources of prebiotic fibers. The gut microbiota need these prebiotic fibers, and that is how the good bacteria will flourish. So you need them. Don't be on a low FODMAP diet for long periods of time, and you should think about how to get them back into the diet. And there are methods to reduce the FODMAPs. And I like to give this example of how tofu, which is firm, has lower FODMAPs as opposed to the silken and the soft tofu, because when you press it and remove the water, the FODMAPs decrease. Don't exclude all fibers. Even during a flare, the soluble fiber is good and needs to be there, because it strengthens the mucosal barrier, and it is something that is needed for good immune function. So don't exclude all fiber even during a flare. Some more don'ts which were covered by Dr. Usha, and this was sugars and sugary foods. Does not mean that a patient cannot have any sugar, but anything in excess, maybe more than 3 to 4 teaspoons in a day, will definitely reduce diversity of the microbiota. The processed meats, emulsifiers and maltodextrins, which we find in ultra-processed foods. And you can see this is one of the foods which has maltodextrin, it has emulsifiers. So these are the ultra-processed foods with many of these agents which are just there to process the food, and alcohol. So these are some more of the don'ts. Gluten, just a minute or two about gluten, because diet in IBD without talking about gluten would not be complete. Don't have to exclude it. There's no evidence to exclude it as a blanket statement that all patients of IBD will benefit from reducing or cutting out gluten. But what you can do is give alternatives if there are symptoms. But the thing is, you first need to document whether there is a need for it. So the diet rules are simple. You have to cut down on processed food, eat more of the whole foods. Diversity is important. Meal frequency, instead of having very large meals, just 3 meals, make it smaller meals, 6 meals. Spices, we tell patients to have turmeric instead of giving them the curcumin. Turmeric have more of the bioactive ingredients in it. So turmeric 5 grams, which comes easily in the Indian diet. Then fluids with lots of potassium, like coconut water and kokum, can be part of the healthy diet. Fermented foods which are fermented, they may not have the bacteria present at the time that you eat it, but if they are fermented, they have benefit, they are better absorbed by the body. So instead of ultra-processed food, the fermented foods are great. And the dark colored fruits and vegetables, preserve the colors because they have the bioactive ingredients in them. Don't destroy it by overcooking. Sometimes you may need to do it to so make the texture a little better, but overcooking at high temperatures should be avoided. So I'm going to leave you with some more food for thought, and I'm waiting to listen to the other lectures and the panel discussion. What I find something that is paradoxical is that emulsifiers and maltodextrins are implicated in the pathogenesis of IBD, yet many of the formulas contain them. And what I've noticed that now there are new formulas coming in, especially for IBD, which do not have these, but up until now, all the success that we have got, even with EEN, have been with these formulas which had emulsifiers and maltodextrins. And we know that over a period of time, if we give exclusive enteral nutrition, they can reduce microbial diversity, but it works because probably it's just working for 8 to 12 weeks that we give them, and eventually when they go into remission, we get back to a normal diet. So thank you so much for your patient listening, and thank you, Rupa, once again.
Thank you. Before we start the panel discussion, Nilanjana, you're wonderful as usual, and I'd request Usha and Nilanjana to please join the panel. I think Iris has also joined us. Iris Totan. She's the Director Division of Gastroenterology at the Rabin Medical Center in Israel. A good friend that comes to me first, of course, when I speak, but she is an IBD stalwart, a global IBD stalwart, a key member and of the International Organization of Inflammatory Bowel Disease. And she will be talking after the panel discussion, but Iris, we'd be so happy if you could join the panel as well and give your inputs. We are doing a lot of work on diet, nutrition, and IBD. And it's my pleasure to introduce Iris and her part of the panel.
Thank you so much. It will be my pleasure to be part of this panel after hearing these fantastic talks.
Over to you, Dr. Manu.
Thank you, Rupa, and welcome, Professor Iris. You have just joined us, and thank you for joining us. Now we've got 4 experts as well as all the 3 speakers. Rupa is also an expert. We're going to take up certain special situations, and I'm going to ask one by one special situation, and we'll begin with Dr. Malti. Dr. Malti, you well known for pediatric management of IBD, so you heard Nilanjana, you heard Usha. They talked to us about how the deficiencies came and what are the way forward. Is there anything special you would like to do in a pediatric age group? I will talk to below 15 years of age.
Yeah, thank you, Dr. Manu, and thank you, Dr. Rupa. We all know that pediatric IBD is a unique topic, though the disease may be seen in pediatric itself. The presentation and the problems vary according to the age of presentation. We have a group below 6 who have a different presentation. If I just take those above 6, the classical presentation, I'm not going to talk about the monogenic IBDs. Even the general IBDs, nutrition plays a very important role because it is the time of growth. And we know that especially Crohn's disease, there is growth failure, which is part of the disease. So that is one point which we feel that, it is little different from the adults. There is a thing that the growth is necessary. Growth failure occurs and steroids may affect the growth. So that is what 2 things which are different from what we see in adults, more of malnutrition occurring them as a part of the disease. Otherwise, in the management, I think Usha took it very well. Diet has been used as a predictor or a causative factor for pediatric IBD. It has been used in the management as an exclusive enteral nutrition, especially in Crohn's disease, especially the mild and moderate Crohn's with a low PCDI score. The Naspagan thing has been said that you can use it at least for first use it for 2 weeks. And then if there is an improvement, if there is a slashing down of the PCDI score, continue it at least for a minimum period of 6 weeks. And, the problem is it is not easy to give the child exclusive enteral nutrition. So sometimes we say place the NG tube, but I have not been. One is it should be mild, moderate, and the child and the parents should be very cooperative. So now in that we are also talking about polymeric formula being as effective as the enteral, either the elemental diet, which is known as the thing, or even amino acid based. So polymeric is okay, but still the child wants to eat what the others eat. So that is one problem we are also facing, Dr. Manu. And then, if you can avoid steroids in that small group, everyone is happy. So now I think now they've come to one conclusion saying you can use partial enteral nutrition using this 50%, and then you can use a diet which is try to avoid the triggering diets, what we call them as the Crohn's disease elimination diet. So when they gave this combination, the results were as good as exclusive enteral nutrition. So you play with the child's mind also. Try to find out what he likes, and then you try to give that 50-50, and we can do that. And then we also say supplemental nutrition is very important because of their diet. I think this is the basic, Dr. Tandon. I think you may have some other questions also.
So we'll thank you, Malti. Thank you. We're going to first go through all the 4 panelists, and then I'll leave it open both for the others also. Okay. Thank you. Uday again needs no introduction. I think no one needs an introduction. He's one of our internationally well-known faculty members. Besides functional bowel, innumerable papers in many specialities from motility to gut microbiota. So Uday, there's a problem that we all come across. You have this stricturing disease, prone to subacute obstructions. You have to give them therapy. What is your advice for stricturing bowel disease? Let's say Crohn's, 2 strictures, diet.
Yeah, so thank you for the important question. So what happens is many of these Crohn's patients, yes, they have stricture, plus they may have fistula. So what happens is that when there is a stricture and the stricture is symptomatic, now this patient has dietary issue, because on one side, if you give wheel hard that the fiber is good, fruits are good, vegetables are good. In fact, epidemiological studies suggested that if somebody is on fiber diet, vegetable and fruits diet, there is a reduction in the risk of IBD. But on the other side, if you give them fiber, if you give them fruits and vegetables, now obviously this is going to precipitate obstruction. So you have no option, but in that particular situation, to reduce the roughage content of the diet. Because if you give too much roughage, is going to have repeated obstruction and the symptoms or intestinal colic. So this is one thing, but at the same time, you have to give him nutrition. So you give diet, which is having good amount of calorie, good amount of protein and fat, but reduce the fiber in it, at least for the period when he is symptomatic. Obviously, many of these patients who have stricturing disease, if you reduce their inflammation with drugs such as corticosteroid, maybe with immunomodulator, maybe with biologicals, actually stricture may open up, because some of the strictures are not really fibrotic strictures, but inflammatory stricture, and these may open up. So as you will see during follow-up, patient will say the diet which I was not able to tolerate, actually I am tolerating better now. So this is what it is. So you have to trade off between having nutrition, enough nutrition to maintain his body weight, but at the same time reduce the diet, which may precipitate obstruction, and treating the stricturing Crohn's disease simultaneously. If on treatment, actually there is an increasing frequency of obstruction, and severity of obstruction. It means this was a fibrotic stricture and it is unlikely to improve just by sort of pharmacotherapy, and they would undergo surgery. One thing here is very, very important. Many of these patients have ileal disease, and if somebody has ileal disease, part of the problem they develop is vitamin B12 malabsorption, because we all know vitamin B12 is selectively absorbed in the ileum. Second thing is, in our population, you can't imagine, like 90% of the population where I work, they are vegetarian, particularly in rural areas. So if somebody is a vegetarian and at the same time he has a sort of ileal disease, now this fellow is going to be B12 deficient. So replace B12, maybe parenteral B12.
Okay, thank you, Uday. We'll come back to you. We'll move over to Devender. Devender, can you unmute yourself? Devender is one of our senior most gastroenterology consultants in Mumbai, and he's done extensive work on IBD, well-known figure in IBD circles. Devender, the question to you is, suppose a patient has been comfortable, we have followed the diet that Nilanjana and Usha have suggested, but he gets an acute flare. Is there going to be a change, a flare which is going to, let's say, last for 4 weeks or more? Is there going to be a change in the dietary pattern, Devender?
Okay, so first of all, I want to congratulate AIG for this very nice webinar, and I have learned a lot from the first two speakers. Now coming to the flare, now our patients who have flare, let's talk about the Crohn's disease, and these may be outpatient or inpatient. So the practical thing that we do, we have initial assessment of BMI, anthropometric measure, nutritional screening, albumin, and we like to do a score, MIRT, or one of the scores which measures not only malnutrition but also inflammation. And we need to have a plan. Nowadays, we are actually checking for sarcopenia also by a simple hand grip strength. So after the assessment of the calories and protein, what is most important here is we need to have a history of dietary intolerances and dietary avoidances. So many of these people avoid dairy and other products, especially fermented products, and there are many religious biases because of which people avoid this. So this needs to be corrected, and the first goal is to see that they get proteins in about 1 to 1.25 grams of protein per day and calories from 25 to 35 calories per day. Assessment by the dietitian after 1 week. If there is no improvement, then they can be protein supplementation can be added. And here I would also like to use eDiary for my patients, and this has been developed, the app has been developed by AIMS Group. In addition to this, we prefer to give either oral or intravenous iron, vitamin D, vitamin B12 and other supplementation as mentioned. Milk, as if tolerated, that they can take. And the coming back, some patients, if they don't improve, then one would consider the enteral nutrition in the form of either exclusion diet or NJ feed or NG feed. So this would be for ulcerative, for Crohn's disease. Now coming to ulcerative colitis, the principles are same. However, I would like to mention one of the recent studies from AIMS where they have used, in acute severe ulcerative colitis, they have used EEN, exclusive enteral nutrition, and they have found that the 7 days of EEN augments steroid response, and it's worth exploring for further confirmation. So this is what I would think about.
Thank you, Devender. We'll quickly move on to Partha. Partha is a consultant at the Asian Institute of Gastroenterology, a very promising author of many papers, and he and Rupa run our IBD clinic. Partha, we've just heard about an acute flare. Now, goes into remission, we've heard Nilanjana and to some extent Usha say that you should be liberal. So what is your advice now? He's come out of the flare that Devendra discussed just now. What would you advise such a group of patients?
The patient of IBD who is in remission, there are a few important factors like the goal in these patients is to prevent the next recurrence and also to screen for this malnutrition, and if it is there, we should correct that. And we should consider few facts like whether it is a type of the disease, like it is a Crohn's disease or ulcerative colitis, because Crohn's disease patients may have malabsorption, and even in the remission, they can be malnourished more than ulcerative colitis. Then also we should see the location of the disease. If it is small bowel disease, it is more malabsorption may be there. And also the phenotype of the disease, as already has been discussed, like stricturing disease or fistulizing disease. Also history of surgery, like ileocecal resection, ileal resection, or more than 60 centimeter of terminal ileal resection. And also an ulcerative colitis patient who had underwent a total colectomy with ileoanal pouch anastomosis. These patients may have B12 deficiency, and who have more than 60 centimeter of terminal ileal resected, they may require lifelong B12 supplementation. So these factors are important. Also, other factors that are important is what was the therapy that was used in achieving remission, and whether it is an adult patient or a pediatric patient, because these things are important, because in children, actually exclusive enteral nutrition is used, that has been discussed, to for induction of remission. So also two studies, one RCT and another control study, have shown that there is a role for partial enteral nutrition in maintenance of remission in these patients, because this after we withdraw the exclusive enteral nutrition, there is chance of relapse almost in 50% patient within 6 months. So there are two studies. Although they lack statistical power, there is some role of partial enteral nutrition in maintaining remission in these patients. And also about like specific diet, most of the there are several diets like specific carbohydrate diet, elimination diet. Most of them, the basic thing is they avoid dairy, processed meat, and the refined sugars. Also the emulsifiers, which calls maltodextrin, and which alters the gut barrier function and gut microbiota. So the basic of these foods can exacerbate a new relapse or new attack of flare in IBD patients. So this should be avoided. And to specifically say for ulcerative colitis and Crohn's disease, for ulcerative colitis, this processed meat and red meat should be avoided, and if taken, can be taken once a week. Normal meat can be taken. Unnecessary or over-restrictive lactose restriction should be avoided. And for ulcerative colitis, the patient should avoid processed meat. Also, high animal fat intake. That should be less than 30% of the total caloric intake. And also, these patients, insoluble fibers, there should be. We should keep in mind about the insoluble fibers like the potato skin or the tomato skin. This may not get digested and cause dietary intolerance. Also, I would like to emphasize that there is a role of vitamin D. If taken in a dose of 1200 unit per day, the studies have shown that it can prevent further relapse in case of Crohn's disease, because Crohn's disease is a Th1 disease, whereas ulcerative colitis is a Th2 disease. The effect of vitamin D on Crohn's disease is more. So they have said that in preventing a relapse in Crohn's disease, there is a role for vitamin D as well. And also in both of them, if the patient is lactose, not a lactose intolerant, milk can be used, because there is a study in which in lactose intolerant patients, there is a double-blind crossover trial that was used in which showed that up to 240 ml per day of milk can be tolerated in these patients. So and other factors are like these whatever be the therapy, that should be cost effective, because enteral nutrition or partial enteral nutrition, they are costly. So it should be therapy should be cost effective and improve the quality of life of the patient. And although the evidence for diet in IBD is not that robust, but we should have use best available evidence rather than no advice, and we should not be unduly over restrictive. Thank you, sir.
Thanks, Partha. Before I'll ask two. Yes, Rupa, you want to say something? No, you are
to say something.
Yeah.
I want to say something because something, related to nutrition and what we missed or maybe we did not discuss. Yesterday, a young girl of 30 came with a flare and she had acute watery diarrhea and then was in hypotension. So I admitted her. We got a scare last evening when they said that she had myocardial infarction. There was classical ST elevation, and they thought that it was an inferior wall MI. So the cardiac team came in, and then she was immediately shifted for primary angioplasty or embolectomy, whatever is needed. Because she was at 30, she was sweating profusely, blood pressure had come down. So during the angio, it was found that it was a clear angio, there was nothing. And then the Dr. Narsimhan, who is our cardiac electrophysiology head, he was called and he said, this is very classical, it happens in IBD that there is magnesium deficiency. And now his comments, he said that this will, and the patient then went into atrial fibrillation. So this was my first time experience of a 30-year-old having this. And he said, even if you check magnesium in the blood, it may not show. A buffy coat magnesium usually highlights it. And therefore, for patients with acute diarrhea in IBD, it may be worthwhile to supplement magnesium. The patient is well today after magnesium. Of course, the cardiac team is taking care of her today. But I thought it was quite a relevant experience to share with everyone.
Yes, that's something new for us, Rupa. Well, we have got 3 speakers, and since Iris has joined us late, I'll ask her. Uday is commenting.
What was the potassium level?
That was surprising. Potassium was okay. We thought that potassium normal, magnesium low, unlikely. And that's what I exactly told the cardiologist. But he did the wonders and the patient is better today.
No, what I'm saying is, sometime hypomagnesemia, when you correct potassium, actually you can't correct in patient of hypomagnesemia unless you normalize the magnesium. So one of the causes for refractory hypokalemia is hypomagnesemia.
Yes.
And hypokalemia can lead to cardiac problem, as you are saying.
Correct. Yes.
Yeah. So that's really amazing because we read in the textbook that magnesium deficiency needs to be checked, but I don't think we do that actively and we really don't pay that much attention. So thank you, Rupa, for highlighting it.
Yeah. So Iris, Professor Iris Dotan, your center in Israel, is a specialist dietitian consultation given to all patients, or you take it up yourself and only call them if there is a tough situation like we discuss special situations?
Thank you so much, Dr. Tandon, for asking this question, and thank you for the wonderful discussion. So actually, you're touching a very important point at the Rabin Medical Center in Petah Tikva, Israel, and I think that in many centers in Israel as well, diet is a central point. And we have, not only that we have several dietitians in the IBD group, we have more dietitians in the division of GI, and every patient is being seen by a dietitian, is provided specific IBD-related consultation, specifically, like you asked very nicely, for a patient with strictures in Crohn's disease, for a patient after pouch surgery in ulcerative colitis, for a patient before surgery and after surgery. So every patient is being seen by a dietitian. And not only this, we are trying to provide an online, so to say, dietary approach, meaning that if a patient came all the way to see us, we're trying that he or she will have the consultation on the same day. And our dietitians are actually equal part of the multidisciplinary team. And actually, I believe that Lihi Godni, one of our dietitians, is online now with you, and Sarin and many other dietitians are participating in the AIG Rabin Medical Center collaboration because we think they are such central members of the multidisciplinary team.
Thank you. Nilanjana, it looks like you and your colleagues are going to be busy with the rising incidence of IBD.
Yes, I hope you give us enough referrals.
Yeah. Usha, very briefly, one special situation, pregnancy. Do you think anything changes from what has gone on, or, we talked about pediatric stricturing, etc., etc. So pregnancy with, extra requirements, just supply extra or something special comes in? No, you are muted. Usha, you are muted.
Thank you, Dr. Tandon. During pregnancy, there is an increase in the energy requirement, protein requirement, and there's also nutritional deficiencies such as iron as well as folic acid, which comes on during pregnancy. So these things have to be supplemented. And if the patient cannot take oral iron, then we can give them an IV iron infusion. This is regarding the micronutrient component. Second problem is during pregnancy, in the initial first trimester, patients don't tend to eat too much because of hyperemesis during the first trimester. So at that time, we don't bother so much with the diet, just continue on an easy diet for them. Later on, when the fetal growth increases, patients of IBD go into remission because during pregnancy, and they will be able to tolerate protein diet. They have constipation, so I would not like them to be constipated, because constipation will increase stasis of the gut and secondary increase in flora. So these patients, I keep them on some fiber containing things so that they have easy bowel movement. If required, we can also add lactulose, which is also a prebiotic during pregnancy. Otherwise, we continue them on the routine diet during pregnancy. We rarely have a problem during pregnancy with handling diet in them.
Thank you, Usha. I think we have come to the end just because we have crossed 30 minutes and more. There may be questions at the end which Partha and Rupa will take over. I'd request Rupa now to please once again introduce Professor Dotan, and we're eagerly waiting to listen to her talk.
So Iris, welcome once again, and it's such a pleasure to have you for this meeting. This is being transmitted across the IBD Emerging Nations Consortium, and so we have more than 20 countries, and people are watching on different platforms. We have it on YouTube, we have it on our Facebook and Twitter, and it will also be archived in our website, the platform that we have at the Emerging Nations Consortium. So this is one of our first initiatives in that line as well. So as I mentioned before, whenever I speak of Iris, friend comes first, but then she is also the head of gastroenterology at the Rabin Medical Center in Israel. And she will tell us about the way forward with diet in IBD and dietary therapy and how things might change in the future. Iris, over to you, please.
Thank you very much, Rupa. Thank you for this very kind introduction. I hope that you'll let me share my screen in a second. I'd like to, while I'm trying to, am I allowed to share my screen? Yeah, this is great. And here is the presentation. And just let me know if you can see my slide.
Yes, we can, Iris.
Okay. So thank you very much, Dr. Banerjee, Dr. Tandon, and of course the audience for this opportunity to be part of this AIG Focus on Nutrition session. Actually, it's been a great pleasure for me to collaborate with the AIG as well as to the team at the Rabin Medical Center, which is the flagship hospital of Clalit Health Services in Israel. And actually, Clalit Health Services takes care of half of the Israeli population. So imagine what would that be in Indian magnitude. But I think that this is very interesting that we can collaborate with you, and we have so many common things with our Indian colleagues. It's really a great pleasure for me to be here. These are my disclosures. And when I'm talking to audiences with the Emerging Nation Consortium, which I had the pleasure of participating in, and really I would like to congratulate again AIG leadership and specifically Rupa and the members of the Emerging Nation Consortium for being so aware of the rising incidence of IBD. That was associated, you know, the title of this, because it's been taken from quite a recent review that you all know from Gil Kaplan and Suen, of course, who's also a collaborator and advisor to the Emerging Nation Consortium. So we see this rising incidence in IBD, and we attribute a lot of it to industrialization and to modern lifestyle. It used to be called Western lifestyle, but of course, as you know, and as everyone who goes to India or to one of the other emerging nations, you can see that it's not only about Western lifestyle anymore, but it's about modern lifestyle in any place in the world. And I think that your awareness is very important, and hopefully you will be able to prevent this pandemic, right? Until COVID-19, we were saying that IBD is the immunologic pandemic of the world, and hopefully you will be able to prevent it because you address nutrition, which I think is a very important cause of the rise in inflammatory bowel diseases. And you already discussed this, so we will not go into many details into the pathogenesis of the interaction between diet and the microbiome, and how, if you can see my mouse, and how the healthy microbiome is turning into a dysbiotic microbiome as the one that we see in inflammatory bowel diseases. And some aspects that were already mentioned, but I will mention some of them because they are important when we're talking about how can diet move forward. So diverse microbiota turns into reduced diversity. We know that this is a hallmark of the dysbiotic IBD microbiome. The mucus layer is actually not researched enough, but the mucus layer is changing not only by its size, but also by its function, thereby allowing bacteria, not only because of the closer interaction of bacteria and the epithelial layer, but also because of the function of the mucus, which is a point of interest of my lab, by the way. And we're trying to see how the function, the changing function of the mucus is actually affecting the interaction of different kinds of microbiota with the epithelium. And of course, last but not least, the intestinal mucosa, with one layer, imagine that, one layer of epithelial cells that differentiate this outer world with its microbiome and nutritional parts, the many enzymes, of course, and secretions of the intestinal tract, from the very active mucosal immune system that changes enormously when we move from the healthy homeostasis to the very disrupted immune consequences of this dysbiosis interaction with the mucosal immune system. So this was trying to highlight the mucosal immune system that was already touched upon. And these are the areas where diet can influence and how diet can affect this inflammation. So you mentioned it already in part, and of course Aryeh Levin, or also from Israel, reviewed this extensively with Rotem Sigal-Boneh, who is one of our prominent dietitians in Israel, and actually looking into how the diet can affect specifically the mucosal immune system, and indirectly by affecting the microbiome and many aspects of multiple dietary components, whereby each one of them can affect, again, as I said, directly or indirectly the mucosal immune system and the microbiome. And then the microbiome can affect directly or indirectly the mucosal immune system, and so on and so forth. So diet undoubtedly is a very meaningful trigger, and as we will discuss, perhaps also a therapy in inflammatory bowel diseases. So we all know for many years how diet can affect inflammatory bowel diseases, and we will of course focus on Crohn's disease, but maybe in the end mention also ulcerative colitis. And we know for years that exclusive enteral nutrition is a therapy for patients with active Crohn's disease. We knew it first in the pediatric population, but also we know it recently also for the adult patients with Crohn's disease, with active Crohn's disease. And actually Tamar Pfeffer-Geek from our division had looked at it specifically in adults and also for adults with strictures, as was so nicely alluded before. So exclusive enteral nutrition can be provided. Usually it is given for either 4 to 8 weeks in patients. This is the duration that patients can usually tolerate it. And of course, it needs to be done together with the dietitians and together with the patients who need exclusive enteral nutrition. Usually its effects are prominent. However, as we would all know, this is hard to tolerate in the pediatric population, where you usually would need to use a nasogastric kind of the nasogastric tube, or in the more adult patients who need to drink these drinks. However, its effects are very prominent. But recently, and you asked me to talk about the way forward. So actually recently we are going, when we're talking about dietary therapy of inflammatory bowel diseases and specifically of Crohn's disease, we're trying to move from the formulas that were given for years for patients with IBD to whole food-based dietary therapies. And one important reason is the intolerance to eating only formulas because of their taste, because people want to eat. Eating is a part of life, and it's a good part of life. And it was very nicely shown before that we don't want to exclude food. We actually want to provide more food, and we want to provide more diversity. So actually recently, very recently, actually in 2019, 2 very important studies were published showing how diet can treat Crohn's disease. First, again, from Israel, from Ari Levin's group, the Crohn's disease exclusion diet. And this is how Aryeh was trying to show its importance by comparing Crohn's disease exclusion diet and partial enteral nutrition against exclusive enteral nutrition. And in this landmark, actually, I think, study, he was showing that Crohn's disease exclusion diet, the CDED, with partial enteral nutrition, where actually processed foods, alcohol, coffee, gluten, saturated fat, red meat, and dairy products were excluded, and a specific menu, a restricted menu though, but still a specific menu, was provided according to a specific therapy, according to a specific schedule, where in certain weeks more and more components are being provided back. And he was able to show the primary endpoint, cleverly enough here, was tolerance. And this diet, of course, was more tolerated than exclusive enteral nutrition, so it was superior to that. But actually, in the maintenance part, it was also associated with reduction of certain dysbiotic microbiota, such as proteobacteria, and improved intestinal permeability. So showing also some mechanistic aspect, not only the clinical aspects. And in the same time, from the UK, the CD-Treat, Crohn's disease treatment with eating diet, was shown in the pediatric population, actually shown for the first time on 5 participants only. But in this study, what was specific was that there was also a mechanistic arm trying to show the effects on the metabolome, on the microbiome, in murine models. And again here, they were able to show that this Crohn's disease with eating diet, that again excluded high fiber foods, alcohol, gluten, lactose. You can see that there are many common parts to these diets, and it was, of course, more palatable than what we used to think about exclusive enteral nutrition, but it also was associated with improvement of inflammation, for instance, decreased fecal calprotectin, and a decreased inflammation, and an increase in some of the outcomes that we want for our patients, for instance, alteration of diversity and improvement in intestinal inflammation. This is why later on, the IOIBD, the International Organization for the Study of IBD, tried to provide some dietary guidance to control and prevent relapse in inflammatory bowel diseases. Now, since we all want to be very evidence-based, so of course the recommendations here are very careful and are phrased in a very diplomatic way, but already we can suggest to our patients that there are some things that are more prudent to use in Crohn's disease and also in ulcerative colitis, and for some aspects it's more prudent to avoid. For instance, in Crohn's disease, and we said that we will focus mainly on Crohn's disease, it's more prudent to add vegetables and fruits, and it's more prudent to avoid saturated and trans fat, emulsifiers, carrageenans, artificial sweeteners, maltodextrins, and titanium, which is coming more and more into the focus. In ulcerative colitis, it is more prudent to add omega-3 oils from fish and food specifically. And then to avoid red meat, processed meats, which have been accused repeatedly to be associated with ulcerative colitis, dairy fat, saturated and trans fats, and again, the others are quite similar with Crohn's disease. So again, we can be more specific in our recommendations to patients with inflammatory bowel diseases. But the important questions that come into mind are how these diets can affect and what is their effect. So a question that was recently asked on a population-based, and two studies again coming in 2020. On your left, you would see the European approach, and on your right, you would see a study from the United States, huge population-based studies asking, can healthy diet prevent IBD? So the answer from Europe, from Sweden specifically, was that yes. Adherence to Mediterranean diet, so they were specific about components of the Mediterranean diet, was associated, interestingly, with a lower risk of later onset Crohn's disease. So they looked at many patients, actually thousands and thousands of patients from the Swedish cohorts, and they were able to show that if they looked, and this was based on food frequency questionnaire components and on outcomes, and they were able to show that later onset Crohn's disease was prevented in populations, was lower in populations that were eating Mediterranean diet. And on a similar concept, but with a different diet, so from Anantakrishnan group, looking again at huge population-based, mainly population-based from the United States cohorts, and they were showing that dietary inflammatory potential was lower in patients that were having an empiric dietary inflammatory pattern that was lower, and in these patients, Crohn's disease, again, specifically, was prevented. Now, this is actually trying, and I'll show you a focus on how we can differentiate between these various, when we say a healthy diet, what do we mean? So I mentioned already the Crohn's disease exclusion diet and the CD treat. We mentioned the Mediterranean diet. There is the specific carbohydrate. You mentioned the low FODMAP diet. So there are multiple diets that are considered healthy. And is there a common denominator? So you see that several of these diets have components that need to be, that are not allowed. Okay, you can see them here, for instance, in the brown rectangles, and some of them are actually mandatory or allowed, and you can see them here in the lighter blue or the dark blue. For instance, specific fruits that are mandatory or allowed in these diets. And many of them are included, as you see, in the Mediterranean diet. So what we actually eat here in the Mediterranean area is commonly recommended by many of these diets. And as you see, the Mediterranean diet pyramid, and I'm sure all of you are familiar with it, excuse me, is actually requesting to avoid as much as possible meat and sweets, and to have the majority of the diet being based on fruits, vegetables, to drink a lot of water, to use in moderation, but to use red wine, and to avoid poultry, eggs, and cheese as much as possible, to eat them in moderation. Okay, and of course, to base your proteins on fish mainly. And when you look, again, if we want to focus on this diet, wait, I'll move this a little bit to the side. So we can see that it is not only based on specific components that are recommended by many healthy diets, but also that it can affect positively some of the bacteria that we want to have more in our patients, and it can affect the bacteria that we want to have less in our patients, therefore potentially decreasing dysbiosis, therefore potentially having a better anti-inflammatory outcome in our patients. And we wanted to take advantage of this several years ago when we were studying diet and the microbiome. And we, as you know, focus on patients after pouch surgery, which we think are a man-made model of inflammatory bowel disease, whereas patients with ulcerative colitis that have their large bowel resected and an ileal pouch is made out of normal small bowel, are developing a disease, pouchitis, that resembles Crohn's disease. And we look at these patients, we focus on them very intensively, thinking that they're a model of IBD. And you see here many of the studies that came from our group. Many of them are done by dietitians, and specifically by Lihi Godni, who is attending these sessions and prepared many of these slides. And our approach to these patients would be that diet would be one of the issues that we are testing, and looking at each patient online. Meaning online is that when a patient is coming, we're asking him or her on his or her dietary habits, and we're trying to modify the diet so that inflammation is decreased based on that. And I want to share some of the that we have from this interesting patient population. We noticed that Mediterranean diet in these patients was associated with beneficial outcomes after pouch surgery. Mediterranean diet was associated with lower levels of inflammatory markers in these patients, specifically CRP and fecal calprotectin. And moreover, that fruit consumption was associated with a lower rate of having pouchitis. So here you see the patients that actually sustained the normal pouch, and these patients actually consumed more fruits and were able to sustain a lower level of pouchitis. Diet was associated in these patients with microbial diversity and composition. And you can see here that these were the patients that consumed vegetables, but more so fruits. And we could also specify which fruits would lead to which different bacteria. And you can see here the bacteria that were noticed in these patients according to the different fruits that they consumed. So we think that maybe you can combine the fruits with the bacteria that you want to modify in a specific patient. And this is coming from another very successful graduate student from our lab, together with Uri Gofna from the Tel Aviv University, that was able to show that dietary fiber consumption was associated with butyrate production. And he was able to show it in patients that were controlled ulcerative colitis, Crohn's disease, those with a normal pouch and those with pouchitis. And you can see that butyrate producing enzymes were positively correlated with dietary fiber consumption. And again, specifically from fruits and vegetables. So I think this is a very important insight from our study. And Lihi Godni is now summarizing two different diets that we were trying to look at in patients after pouch surgery. One of them was the Mediterranean diet. One of them was a specific carbohydrate diet. And she cooked and provided those diets to our patients after pouch surgery, and was able to show that rapidly and personally they affected inflammation in multiple mechanisms. And I'm showing you here only part of them, but they were affecting clinical parameters, quality of life, metabolic outcomes, microbial composition, of course, and even we are looking at the epithelial barrier function in these patients. And what she's doing now, she's trying to show us how these interactions, these multi-omic interactions are changing in patients, whether you are giving them the Mediterranean diet or the specific carbohydrate diet. And what we're suggesting is that one side does not fit all, and you should fit the diet like you fit the medication, like you try to combine infliximab to a patient with IBD, maybe you will fit Mediterranean diet. So this is what we think about road ahead, and now we are combining an IBD Mediterranean nutritional education program so that when we tailor the diet to a specific patient, we can personalize how he or she are using this diet. And actually we tried it, I'll finish by that, we tried it first on ourselves. So you see here, this symbolizes many participants, not patients, hopefully, from our group. And we did this IBD Med intervention on us, and we used this educational program, and that improved the adherence to Mediterranean diet in healthy controls. These were us, members of the multidisciplinary team. After 1 month, so this was the daily med score, we were adherent more to the diet that was suggested. And after 6 months, we were quite good in it. You see that we didn't go back to our bad habits, but yes, it needs to be like maintenance therapy. It needs to be educated and re-educated. And talking about the collaboration with the AIG and with our Indian colleagues, we found many common denominators between Israeli or Mediterranean food and the Indian food, and I'm sure that many of you can recognize here Indian foods, and here you can see the Mediterranean counterparts. And now we are trying to see how Mediterranean the concepts of the Mediterranean diet, and this was prepared by Sarin Eliel Fatal, another fantastic dietitian from our group, and you can see here your foods. I hope you can recognize them. And here you can see our foods from the Mediterranean basin. And now we are going to share them with our Indian colleagues, hoping that we might modify disease in India and in Israel when we're treating patients with Mediterranean concepts of the diet. And here you can see our collaboration, and I'm sure you can recognize some of your colleagues and some of our colleagues in these discussions that we are already ongoing, and hopefully we will be able to have more and more interaction. So when we're talking about the way forward, I hope that I was able to reiterate how diet and the gut microbiome play a role in IBD pathophysiology, and the diet and microbial composition and function can be changed rapidly after dietary interventions. And we think that microbial targeted dietary therapy interventions are the way forward, and we need to stratify patients so that these diets can be given specifically to them. And diet, of course, I don't need to say to this audience, is an integral part of the multidisciplinary care of patients with IBD. And with this, I'd like to finish and thank you for your attention. This is our center in a very sunny day like today. Hopefully, we'll be able to see all of you here soon. Thank you very much.
Manu, you're muted. I think we are all speechless after your talk, Iris.
Thank you very much, Rupa. And I'd like to thank Lee Godney, who prepared many of these slides.
Yes, so I thank Lihi also. We know how sincere she is, and I think the kind of works that you have shown is actually going to make the difference in management. As we go on one side from one biologic to the other, I think all our patients will love what we have discussed today and the future as you show it. So, any questions from our esteemed panel?
Well, we've got a list of questions. Most of them have been covered, Rupa. You know, FODMAP, gluten, Mediterranean. There's just one very briefly I'll ask, anyone can answer, maybe Professor Dotan. Smoking and alcohol, where do you place that? Maybe not as a diet, but as a instruction to the patient.
Yeah, very important, because of course it's not only diet, it's the environment. And in this environment, smoking is not allowed. We recommend all our patients, Crohn's disease and ulcerative colitis, should not smoke. Smoking by multiple aspects affects the mucosal barrier specifically and not only. So smoking, we recommend that patients would stop smoking if they smoke. That's one thing. And of course, alcohol, as I said, red wine is recommended in moderation, only a few glasses per week. Okay. And other kinds of alcohol, of course, we ask them that they would be as limited as possible.
Thank you. Usha has got a question. For whom is it, Usha?
It is for Iris. Thank you for a wonderful lecture. I have just two quick questions. One is that once you start a person on a diet, how long do you think it would take to change the microbiota? And how long will it sustain itself? That's one question. The second question is, when a child grows in the first 5 years of life, that time, whatever the child ate at that time, the bacteria which the child is carrying at that point of time when he is growing well, is the kind of food if you replicate in adulthood during the period of an IBD flare or just in remission, do you think that would be more customized and personalized for that particular person?
Wow. So these are fantastic, of course, questions. The second one, of course, I cannot answer yet. And you know that we think that even what the mother is eating might affect how the child and the immune system is growing. So I would deduce from that what is he or she are eating when they are children would be also effective. So I think that the general answer is yes, you should modify the diet for children. And of course, I think that as much as possible, specifically for first degree relatives, you need to be very careful about the diet that they eat. So I think, I don't know if I answered your question in that. And the specific question of the first one was,
how long does it take for the microbiome to change and how long is it sustained?
Yeah, because the first part of it was how fast and how fastly he already showed us that in a week you might change the microbiome. For the second part of the first question is how long we don't know yet. We are following up on these patients, but I think that like the education that you see that is going down after a few weeks to months, so I think this would need to be reiterated, so to say. So if we change the microbiome, you need to go back perhaps every month, perhaps every 2 months to this same dietary program. So I think it's not only about the microbiome, it's also about the education. So like diet is a way of life, right? This is why we're trying to make it as close as possible to your way of life, because I'm sure none of the patients would like to go back again and again and again to exclusive enteral nutrition. But maybe to eating more prudent diet, perhaps yes. But these are fantastic questions, Risha. Thank you so much.
Sorry, Iris, I think I didn't express myself correctly for the second question. The second question was, if somebody is having IBD today, he is say 30-year-old, is it a good idea in personalized kind of medicine to ask him to take what he took when he was 5-year-old, when he was growing well? You know, he goes back to his diet which he took when he was 5-year-old.
Okay.
That's a good question.
Right, Rupa, what do you say? Of course, I have no answer.
I have never done this, but you're giving me ideas, Usha. So the child can go back to the Cerelac and I think Manati will be able to answer that well.
Actually, by the
but what you ate when you were a 5-year-old, when you were, that's what your mother was feeding you and which you liked eating.
Yeah, but by the age of 5 years, you take family food. You share the family food. So there's not much of variation.
I agree.
But only thing that time there was a little bit of obedience. After that, the disobedience starts.
Your question.
Yeah, just one question I wanted, because now whether you take CD treat or you take CD-ED, that is, or you take whatever diet, gluten is so much of emphasis. In our part of the thing, South India, we're able to give them, wheat, rice based. But there are some without. How are you all managing? I just want Dr. Uday and Dr. Usha. Is that important? Even Iris can tell us. Gluten, that amount of thing now. Are we doing it wrong? Have we been doing it wrong? Have we been giving wheat chapati to them when they should not have had? I don't know. Did we make the disease worse because of that?
I think the gluten-free diet, the marketing has been faster than the progress in the science.
Yes.
So when the marketing people start marketing things, but they actually go so far forward compared to what science does. It takes time. Science takes time. So what I'm saying is gluten-free diet is purely for celiac disease. But when we talk about irritable bowel syndrome or inflammatory bowel disease, every patient need not be on gluten-free diet. No way. In fact, I hardly ever see a patient where I have to totally stop gluten. But suppose it depends on the preference, I would say that do you prefer rice more than the wheat? What do you like more? Like if you ask me this question, I'll say rice. Like in my childhood, I've never taken wheat. I was in Bengal, so 3 meals were all rice. So it is when I moved to North India, I started eating wheat, What I'm saying is that therefore the gluten-free diet is not recommended in every patient. If the patient is having a lot of flatulence, maybe a lot of bloating, maybe he specifically tells you when I take wheat, I'm bad. Now these are the patients and those patients are occasional, fortunately.
Yeah. Nilanjana, question from you?
Yes, my question to Professor Addis. I wanted to know her view on probiotics and whether there are any strain-specific probiotics that she uses are there any foods that they recommend which have probiotics in them?
So actually, we are very interested in probiotics because, as you know, we have this pouch clinic, and probiotics are where they were approved in the early 2000s by the Italian groups mainly. It was in patients after pouch surgery. So we were very keen on probiotics in the beginning. As the years went by, I have to admit that we less and less think that probiotics are the answer to everything. And actually, like I said for the diet, it's probably like one diet does not fit everyone. So one probiotic is not unanimously given to patients after pouch surgery. It should not be given unanimously to patients with ulcerative colitis. Like you have seen recently in the literature, perhaps take one specific probiotic or a combination and try to combine it to a specific situation. But we're not giving to the short answer, we're not giving probiotic to every patient, not even today to every patient that is taking antibiotics.
Oh, okay. Thank you.
I think regarding diet, we can go on, but and this has been a wonderful session. And I thank Usha, I thank Nilanjana, I thank Iris, I thank our eminent panelists, Dr. Malti, Dr. Uday, Dr. Devendra Desai, and of course, Partha has been with us. So I think we'll have further sessions on this. And I hope that all of you liked it. Robin, could we have the last slide, please? So I also would like to take this opportunity.
Share your slides. Slides are not shared.
Robin, can we have the slide, please?
Sharing. Robin, sharing. We can't see that it's in the small screen. I can make out IBD masterclass, Rupa, but the smaller words cannot be picked up.
So I think by the time that Robin puts it up on the screen, I would take like it
if you want. If you can pin it on your own screen if you want.
I don't know how to do that.
Just right-click it and do pin.
Boy,
Usha,
that is high-level technology.
I've done that.
So 2 things. One is I'd request all of you to become members of IBD Emerging Nations Consortium. This is a group where we all share our difficult cases, challenges, what we learn from each other. And you can see all of us there in the group photo that we have. Registration is free. And we would request you to share your papers, your articles papers for the region. Journals, every top 10 articles every month, latest news. Then we will also have starting the IBD masterclass. So next month, second Friday every month, we are starting the IBD masterclass. We'll keep all of you posted. Small sessions, 1 hour, 1.5 hours, but all about IBD and the variations of this chronic, lifelong condition. So thank you once again. Thank you, Iris, for joining in on a working day. And good night, everybody. I'd also like to thank Abbott for supporting this educational program. And we hope to do much more on the same platform. Goodbye. And
Thank you, Rupa. Thank you.
Thank you,
It was
everybody.
great.
Thank you.
You are our OPD.
Thank you.
Thank you.
Thank you.
Great learning for all of us.
Bye.
Thanks, Nilanjana. Thank you.
Bye.